Hello to QI Talk Timers and welcome to today's QI Talk Time, the first QI Talk Time of 2020. I'm delighted to have Philip Crowley here today with us, the National Director of Quality Improvement. We're going to talk today about the strategic approach for improving quality 2020 to 2024. So we're not going to labour too much on Philip's bio. I think you all probably know him, but he's the National Director for Quality Improvement and a GP by background, and has extensive training in quality improvement. So we're delighted to have Philip with us here today to share with you our strategic approach, and we're hoping that this will be as interactive as possible. So the dial-in number is 015260058. The event number is 848-655-029#, and you'll see that in the chat box. If you want to listen over the phone, the sound is generally better over the phone, so do that. We want to answer any of your queries or address any of your comments throughout the webinar. So the chat box will be active. There is a little bubble in blue you'll see in that pictorial there. If you click on that, you will have the opportunity to type in any questions or comments or queries there, and we will have time at the end to answer those. We are very active on Twitter, and I think there's quite a few new followers to QI Talk Time who are joining us today, so you're very welcome. If you'd like to tweet, our Twitter handle is @QI Talk Time. If there's a few of you in the room, let us know, because a lot of people are using QI Talk Time as a vehicle now to meet in their own organisations to get that quality improvement conversation started. So please take a photo and tweet it and let us know if there's a few of you in the room. So without further ado, I'm delighted to have Philip here with us today to bring us through some of the work that we're involved in and how you might get involved. So we'd love to get a conversation going with you all on this. So delighted. Thanks, Philip, for joining us and kicking off our season for QI Talk Time. We've an exciting lineup of speakers, and we'll come to that at the end of the talk today.
Great.
Okay.
Thanks very much, Roisin, and very nice to be talking to you all today. Maybe it's unusual to start with a slide on challenges, but really what we want to talk to you about is what can we all do to really up the game on quality in general, to improve care, to deliver on what we all want to do, which is to do a better job and to get better care delivered. And that's just a few ideas around that I want to kind of share with you today, and to assure you that we will be working in partnership with all of you to try to progress this agenda over the next 3 or 4 years. But at the same time, there's no point in talking about anything that we're going to plan to do without acknowledging, particularly at the moment, the extreme pressures that health services is under. And while that's an acute services image there, obviously community services are equally under massive pressure. And I think it's fair to say that this is a challenging environment for us to really improve care and to come in and do the good job we set out to do every morning when we come into work. And that's really all any of us want, is to be able to do the job we signed up to, that we trained to do, that we're professionally capable of doing, and not to be thwarted by the environment we're working in or by the pressures we're under. So I think, we know what the challenges are. There's financial challenges, there's access challenges, and we do this work fully cognizant of the frontline reality. I still work in the front line. I do general practice work in Merchants Quay, and that's quite pressurized in its own way. But so I'm aware of the conditions in which we have to work in sometimes. But they aren't just kind of service challenges. They're also kind of challenges around how we kind of work in the health service. And there's an awful lot of competition between organisations and institutions that would be much better replaced by coordination and collaboration, and very much that's the ethos with which we come to the table with. We also have quite a reactive system, inevitably reactive because it has a lot to react to, difficult situations, adverse events, etc. But we really need to be more strategic and more proactive if we're going to really think our way through these issues rather than be bogged down in them all the time. And obviously we're creating new integrated organisations, and that's going to be a big step towards integrated care, but it's not integrated care in and of itself. We have to work differently if we're going to really integrate care. And we need to be better at prevention, I think, because we spend an awful time patching up issues and health problems when we should really be getting in earlier and supporting communities and individuals to live healthier lives. We have inequities to deal with. particularly in terms of access for secondary care between public and private patients, something that I'm not comfortable with. And we also have significant issues in our culture and very hierarchical decision-making structure. So that's, if you like, a system reality. I think that we can see those challenges, and if we're aware of them, we're far more likely to work kind of consistently, coherently, acknowledging those challenges and trying to deal with them as we go. So what is quality improvement? Maybe this webinar doesn't really need to dwell too long on that, but this is the definition we've come up with for our strategic approach. There are lots of definitions that are a bit more kind of technical about scientific methods and all of that, but I believe it's much wider than that. And it really is the efforts of us all, that's people who use our services and people who deliver them, to really focus on better patient outcomes and better patient experience and service user experience, and continue to support staff, particularly in delivering better care. So I just come back to this idea that quality is not like a technical solution to a technical problem. It is much more than that. I mean, we can fix things. You know, there can be something wrong, and we can apply quality improvement methodology. We can work out a better way of doing it, fix it, walk away. But if the environment and the culture are all still very similar, where maybe the problem had arisen in the first place, and the culture and the work environment has something to do with that, and we don't address that, then I don't think we've created a quality solution. We've just created a fix. So that's why I think it's hard to sustain improvement if we don't address issues of environment and culture. And our staff survey shows a significant amount of bullying, and also staff not being involved in their own ideas about how to improve care. So there are things we now know and we can address. Okay, when I say we, I mean you have achieved many things in the past in terms of quality. I mean, I go to quality days, and it's phenomenal the improvements that staff have instituted right across the country in community settings and hospitals, right off their own bat, often without any support from anybody at all, still doing their job full on, and yet improving care. So this is what we need to build on, and we've partnered with frontline staff to do various things like short rounds and reducing pressure ulcers, getting the No Check Ask campaign going in medication safety, decontamination, et cetera, et cetera. We could go on, but these are all things that we have not done. You have done them, and we've supported you in doing them, and we continue to do that work. So just to quickly go through how we intend to organise ourselves in relation to, I expect actually you're going on through that, yeah. Let me go to that first. Sorry, I'm just going to skim around the slides a little bit in different order. This is basically how we organise, or plan to organise ourselves in this new kind of strategic approach to embedding quality at the centre of everything that we do. And that means that if quality is the quality improvement team's job, then we're done for. That will not get quality done. It will not get improvement done. It becomes an approach where senior management sign up to it, where leadership in the system sign up to it, where we work with frontline teams to enable them to do it. And this is how we're going to organise to help support all of that. So I go through the different branches of that organogram now as we go through the talk. But I won't spend very long on them because I think you know kind of how we organise ourselves anyway. That's just a picture of our team, very nice picture taken at our annual meeting. And really our purpose is merely to support you to enable sustainable and lasting improvements in healthcare. We can mobilise our knowledge and skills, but we can work and build on your knowledge and skills, which is really the origin of our knowledge and skills in the first place. Because we learn everything from our work with you. So basically, the way we're going to organise, we're going to really up our game in relation to communications about quality improvement, really ramp up our work in social media, continue to support networks and communities of practice around improvement, improve our communications in general. We're going to continue with these webinars, which I think have been really quite successful. We're going to try and expand the participation in them, and we're going to continue to support Schwartz rounds as well, which I think have been a positive contribution to staff well-being and staff morale wherever they've embedded, and they're embedded in many places. In terms of the safety work that we're going to continue to do, obviously under the umbrella of this patient safety strategy, we're going to continue to work on pressure ulcers, and we started working on falls and early warning score. Medication safety work continues, and we continue to support boards in leading work on patient safety. And then in terms of work that we do around supporting our staff, in terms of knowledge development and capacity building, we have a School of QI now. It's kind of just renamed, if you like, small group of people who will be generating offerings around starting up into getting into quality improvement and more in-depth work in quality improvement. We'll continue to work on the diploma that we participate in with the College of Physicians. And we'll continue to do loads of work around building capacity and quality improvement for people out in the system. In terms of evidence for improvement, we're really starting to get places in relation to changing how we look at data so as we can start measuring over time, start sifting out background noise from actual events that are happening within our data, and also, trying to use data to generate improvement rather than just pass-fail, arbitrary targets, and all of that. So we're making a lot of progress in that regard. The executive management team and the board are starting to look at that data, and we hope ultimately for it to be how we look at our entire performance in our performance report on a monthly basis. We'll be looking at a whole series of other pieces of work as well, hopefully training people up in QI methods for improvement, measurement for improvement methods, training analysts and others who are interested in that throughout the coming year. So in terms of, we do an awful lot of work, obviously, with patient groups and patient representatives and service users, and we have two very able patient representatives, Irina and Maureen, on our own management team. And the power and value of that, I couldn't underestimate or overstate. I think it's really a key method to finding intelligent ways to improve care. And the service users and patients are the people who really make sure we sustain it as well, because they won't let us off the hook. So we're doing a whole lot of work through Greg Price and his team with various patient groups and working with the system to enable them with various tools and advice as to how to engage patients more effectively. We're also doing, under that general umbrella, we're doing a lot of work, obviously, on open disclosure. On one level, we kind of thought we'd done our work on open disclosure, and then it blew up again. And so we're now, we've re-enhanced our offering around open disclosure, and we're continuing to provide leadership nationally on that. And also preparing for the Assisted Decision-Making Act, which should be enacted, we hope, shortly or as soon as possible, because we very much welcome this act as being a key human rights contribution to how we deliver care. We continue to do some global work as well. Mainly in Mozambique and Ethiopia in terms of the national team, but we support partnerships through the ESTER partnership. Whole ranges of frontline staff who have shown the initiative to show solidarity and support for colleagues in developing countries, and it's amazing what the people with so much fewer resources than we have can do and have done in partnership with ourselves, and we're going to continue to do that because we think we learn a lot from that, and we think it's part of our global vision. And something that we should continue to support. And finally, we're going to continue to work around clinical leadership, particularly the Clinical Director Program, which I'm responsible for, and provide training for clinical leadership to ensure that they're as effective as possible in embedding improvement in the way they look at things as well. So why are we bothering to have a new document, a proposition around a strategic approach to embedding quality? I think it's because we all know there are many, many challenges for sustaining the work that we do, and we think a strategic approach to improving quality is what's going to, really framed around the framework, which I'll come to in a second, is really how we're going to build sustainable improvement. I mean, you hear all the time people are, they start off something and it's wonderful, and then they get shifted off. The guys doing this are all gone. It's too busy to keep it going. We fixed it, but nobody seemed to notice, and nobody said thank you. That's pretty demoralizing. The old way was easier, we kind of went back to it. Or we've got a great big new idea, so we've forgotten about that other new idea, and we were going to go on to this new idea, and so we don't sustain things. And that's not a criticism of anybody, it's criticism of myself, really, that we haven't thought our way through to a more sustainable approach. So that's really what this is all about. We still very much understand things through the prism of the framework for improving quality. The key drivers for sustained improvement are leadership, and that's collective leadership, engaging people and families, as I've already said, really enabling staff to lead on their own ideas. So getting out of the way of frontline staff and creating an enabling environment for frontline staff. And that's something I'll come back to that maybe we could all make a contribution to. Using improvement methods I've already discussed. and measurement for improvement, and then putting it at the centre of governance, which is partly what this strategic approach is all about, and it's ultimately about changing culture. So we've been on a bit of a journey in Ireland over a number of years, and I've been involved in and out of these different initiatives. I was involved in setting up the Madden Commission that was seminal, provided a seminal report on how to improve quality, and it was really a response to the Judge Morning Harding Clark's review of Michael Neary's practice in Drogheda. We set up a Quality Patient Safety Director, which I led, and then now the Quality Improvement Division. And now I think we're with the Patient Safety Strategy. This is our offering to the system to see how we can strategically ensure that quality is not lost in all of this. Going in the wrong direction there. So reflecting on 5 years really of working in QI, because prior to that we were very immersed in adverse events and all of that. We've had 5 years to really reflect on what works, what doesn't work, how can we be more effective in supporting the front line. We've interacted with a lot of international systems, which I list there. I'm not going to go through them, and what they do. And we've come up with kind of a recipe, a manifesto, set of ideas. And these are things that any of us can bring back to our own workplace and say, what can I do about this? How can I make my environment, whatever anybody else is doing, how can I make my environment more reflective of these kind of key building blocks for a quality-focused health service? I mean, it really is built on, and the evidence is very clear for this, and I quote evidence there as we go through. It's built firmly on partnerships with people and staff. If we get a relationship with our staff and your relationship with your own staff right, then they'll get the relationship with the patients right. I mean, and the service users. So really, we need to think seriously about relationships and how we work with staff, particularly in the front line, and enable them to do their job better. We need to promote an environment where research is welcomed, where we share learning, and we don't just achieve learning, we share it across the system. We need to invest in quality improvement specific posts, not ones that are kind of adverse event, risk. They're important, and we've got to get that right as well. But we need some quality improvement specific capacity out in the system, and we will be, and there's a lot of people support, a lot of evidence to support that in the system, in the literature. And we need to train all the staff in quality improvement. We intend to do that. We intend to make an online offering available to everybody. We have a quality improvement toolkit now available online on our website, and I would commend all of that to you. We need to work on culture, though. I mean, it's not just around going around fixing things. It's understanding the importance of relationships and staff feeling valued and their input being encouraged. And part of culture, if we're talking about safety, is, of course, safety policies as well, situational awareness. And so we'll be promoting all of that as well. And these are all things that anyone can do in their own workplace. We need to work fundamentally with managers to create a work environment where staff themselves are able to work on improving care. They can improve their own area of expertise. Everyone is expert in their own job. I'm not expert in anybody else's job. So we need to show no hierarchy of respect and really understand that everybody can work on improving care. And if you can create an environment where you work that enables that, then that's a giant step forward, I would say. We need to use measurement for improvement approaches, said all that already. We need to put it in as not a priority. Quality is not a priority. Quality is our way of doing business. Quality is what we're obsessed with, what we think about, what we govern, what we ask questions about, what we talk about, what we raise in meetings and discussions. We need to work to integrate services. Integration is a massive challenge internationally. You go anywhere, you talk to any international consultant, they say integration is the #1 issue for health services and for ours as well. And then finally, I'd just add in something I suppose that's kind of dear to me. I've done a lot of work with community organisations over the years. And communities are really part of their own solutions, and they've far more capacity. And we look at communities often as having deficits. We look at their deprivation rating, we look at illness rates. I mean, we can think of particularly poorer communities as having a lot of negative aspects in terms of outcomes. And sometimes health is unequally distributed in that way. But those very same communities are the communities with the greatest strengths very often, and organisations and supports for people that we should be tapping into and working with. So I think I think people are progressively starting to think about health services being much more in partnership with communities. So if we integrate care in regional healthcare organisations, we need to integrate it right out into the community, into non-health service organizations who are providing solutions to the fundamental issues affecting our service users and patients. And we need to continue to concern ourselves with equity and equity of access. So that, if you like, are the 10, if you like, kind of ideas that most consistently come out of the evidence and most consistently chime with our experience of having worked with you over the last 5 years. And were fundamentally reinforced by a series of interactions we had with frontline teams, with patient organizations, with colleges, with delivery organizations, with the hospital groups and the community healthcare organizations, where we had a discussion that helped frame this strategic document that we're now, well, we're formally launching it tomorrow, but we're sharing with you today. So where will we get to with all of this? And I'm going to finish very soon because I really would like to see if we can generate discussion. I don't want to hog this because this is what we think. We haven't made it up. It's come from, as I say, a lot of discussion with people like yourselves around the system, and from looking at the evidence and talking to international colleagues. But what we really want to talk about is how can we bring quality alive in everything that we all do. But what would be the outcomes if we really achieve this? And all the evidence is to show that people who use our health services will get a better experience. If we fundamentally enable frontline staff to improve what they see fit to improve and think is important, if we have a different relationship with patients, and if we have a leadership that's really collective and respectful of others and humble in nature, these are the outcomes that are achieved. And there's lots of evidence to show that. This is what works. And when it works, we achieve better experience, better outcomes for patients and service users, less harm, obviously better collaboration and more trust. Trust is really crucial, I think. And obviously greater participation in decision-making is one of the things that achieve those earlier outcomes. And in terms of for our staff and people who are delivering services, people will have higher morale. They will find they're using their skills more effectively. Their ideas are being listened to, and they're more involved in their workplace, and they're getting opportunities to lead improvement. And we'll be developing networks out of all of that so that people can support each other. Because it's just we've got to keep this going. We've got to really support each other as well to keep this going, because there'll be ups and downs, and there'll be times when it's harder than others. And in terms of the organizations abound in the literature that have adopted this kind of quality-focused approach, where they're obsessed with quality, where they develop a quality strategy, where they enable frontline teams to deliver on their ideas, et cetera, et cetera. They build capacity, they have quality improvement roles and people with quality improvement skills throughout the system. They're measuring more intelligently. These are the organizations that have transformed their performance. And the evidence for that is multiple and spread right across the literature. And then in terms of the health system, we could really start putting this together in a whole series, or delivery organizations starting to really embed all of this in everything that they do. And really, it's only embedding what's already there. I'm not saying that this is all new. I'm not saying that people aren't already doing this. What I'm saying is it's not as prominent as it could be. And I think if it was more core and more about how we do our business, the whole health system will show improved level of performance. There will be better. There will be less us and them in the system. I think we'll have more people pulling together, more support from the centre to the front line, better use of resources, more efficient. We will achieve cost savings through much of this work as we do already, and better, more learning organisations. All of this is only going to improve staff and patient experience, and that's really the whole point of it. So finally, why? We've enough documents, haven't we? Really, we've enough strategies, we've enough plans. We're always criticised for being great at developing plans, but not so great at implementing them. I would say why we want to do this is why we want to share this. Really, is we want to share the upshot, the outcome of all of these discussions we've had with people about a shared approach about how we can all best support a sustained quality improvement in frontline services. Because I think we can improve, and sustaining the improvement is the real challenge. And then getting improvement in quality basically at the core of everything that we all do. So we start shifting things all over the place and cracking difficult problems everywhere where we work. That's really when we start to see organisation-wide and system-wide improvement. So that's why we think a strategic approach is relevant, why we think this approach is coherent, and why we commend it to you. So it is a plan really, from our perspective, to our plan to how we're going to partner with you to deliver health services to address the kind of challenges that I've outlined at the start, and ultimately to improve our experience of delivering care and our customers' experience of receiving it. So that's really why we're doing it. We care passionately about that. We believe the set of thinking in this document is helpful in order to get there, and we believe that essentially that only working together will we be able to tackle all these challenges. And I think you all know that, and we all know that. We really need to pull together. We need to develop new thinking. We need to listen to your thinking. We need to create environments in which your thinking prevails. Where it's tested, though, I mean, good ideas aren't good enough. That's why we have a method for improvement, so to contest our ideas. Because sometimes good ideas don't work, and we have to accept that. Doesn't mean they weren't a good idea, but they didn't work or they don't work. So we have to test them rather than just implementing ideas willy-nilly. So it's not about a helter-skelter approach. It's about something where fundamentally, though, the ideas that are generated by people at the coalface are ideas that are tested and implemented when they work. And that's the healthcare system I want to work in, and I think it's the healthcare system most of you want to work in as well. Certainly the people who I interact with on a regular basis. This is what I'm hearing, and this is why we have the document. So that's really all I really wanted to say by way of presentation. I think we've still got a good bit of time to maybe have a discussion and see, what do you think? This document will be up online on our website probably later today, and there's a whole series of other ideas and thoughts in it. It's a companion piece, though, to everything else that's on our website. As I say, the Quality Improvement Toolkit draws together all our advice and guidance around different methods for improvement, and we have lots of guidance up there on how to engage patients and staff. So the whole series of all the drivers have got some kind of form of literature and guidance on our website, and I commend all of that to you also. So that's really what I wanted to share with you today by way of presentation, and I'm very keen to hear any comments or ideas or what next, or what should we be doing now.
And just to go back on what you said there, Philip, about the available guidance online. So qualityimprovement.ie, if you go on to the website, there's lots of really useful information there. So please check it out there. But do send us your email address, and if there's a particular area that you're interested in and you want further advice or be put in contact with somebody with specific expertise on a particular area, please do that and pop it in the chat box and let us know. Now, we do have time for questions. Everyone's very quiet there online, so please type in any comments or queries or challenges that you have in relation to quality improvement. One thing that sparks the memory for me is my work that I would have been involved in the NRH, where they wanted to, as an organisation, create their own network internally for quality improvement. And there was lots of aspects within that in terms of, getting people together in the room. People are already busy. There was no one with a dedicated role for quality improvement. So how do you even get started? But it was just getting those people in the room together to have a conversation and to build on that. So it's starting small, and it does take time. This is a journey. And as Philip talked about earlier, we've been on a journey as a team. So really important to look back and think about that. So I think I would direct you to, if you are interested as an organisation, to come together and try to build your own internal network for QI, through which a lot of this work could be progressed. If you look back at the Quality Improvement Talk Time, the QI Talk Time webpage, there are two really good talks, one from the University of Limerick Hospital and from UL, and another one from the NRH, where they both talk about developing their own internal communities for QI, which I think is really crucial in terms of getting that, building the will and getting people together to get the conversation started, through which a lot of these things can be tackled. Would that be right to say?
Yeah, absolutely. And I suppose the other thing is, I suppose we work in an organisation that doesn't always empower us. So therefore, I suppose we can sometimes feel a little bit like we need to wait until somebody allows us to do something, or somebody says, okay, this is what we're going to do now. We wait for them to tell us what to do, if you like, or to allow us to do what we think should be done. And I suppose what I'm positing here is just to think about, well, while we're waiting for them to get their act together, what can we do? What could I do in my team to create an environment where relationships are obviously more valued, where people are more listened to, where we have a different relationship with our service users and patients, where we start to see people blossoming from all the different members of the team, different professional backgrounds, different non-professional backgrounds, whatever background people come from. People have expertise, and I have a series of slides which I use sometimes in talks with pictures of people, and I've obviously requested their permission to use them. But people from, portering, people from catering, people from lab-based backgrounds, and some of the things they've done off their own bat in their area. And while you wouldn't ask your caterer to redesign how we stent people for heart disease, you wouldn't ask the cardiologist as to how to create healthier diets and ones that are more responsive to patient requests. So, I really, if I believe anything, I firmly believe that everybody brings with them every day when they come into work very profound expertise around what they do, and we need to start letting them act on that.
Great, and just to say, actually, with the QI Talk Time, we are really interested in the second half of the year. We're going to look at tapping into those local networks in organisations around the country and trying to broadcast some of our QI Talk Time from different areas around the country, be it hospitals, community healthcare organisations. So that will be a way, again, of tapping into those local networks and trying to join people together where possible. So just keep that in mind. If you have your own local QI network, we'd certainly be interested in linking in with you to help develop that further. Some questions here. So Ruth Creighton has asked about the engagement. She's found the engagement guide from QI very informative and useful. Curious to hear your thoughts around the interface with the change framework and guide.
Oh yeah, well, we've great relations with with HR obviously, and with our colleagues who've developed the change guide. And you'll see QI is very central to that. We wouldn't see a huge difference really between the two. There are subtle differences between what we offer, I suppose, and what's in the change guide. We will work increasingly closely with Alan and Katrina, and I think I see it all as part of continuum. So equally, like say when we talk about improvement, I suppose we've traditionally taught the model for improvement, which is the IHI model, and we find that's pretty effective. We've recently trained up in Lean as well, and that's another method that's effective, and I must say I really enjoyed that. So we're kind of agnostic as to how we go about any of this, so long as we start to attend to some of those 10 fundamentals about creating an environment in which all of this is more likely to happen. And that's really what I'm kind of saying to our own leadership team here, and I'll be bringing this back to them now. And but they all fed into it as well in the first place, and we'll obviously be sharing this now widely with the system as well to generate a further debate about how we move along this road to really quality-focused healthcare.
Yeah, and I suppose just to say as well, we are looking at mapping on our QI onto existing things that have developed. For example, there is a huge growth in frailty teams around the country, and this year we're hoping to tap into that. So our way of working is trying to, bring QI to already existing networks and enable them with QI knowledge and expertise. So we will be, hopefully some of you online will have an opportunity to avail of that in the coming year. Also, we're hoping to work with the ambulance service in a similar way, potentially progressing how they do QI within the ambulance service, a more, I suppose, organised approach for QI, which is something similar to what we're talking about here. How do we showcase the QI that we're doing? Because there's a lot happening out there, and often we don't celebrate it or showcase it. So it's giving us that, I suppose, frame through which we can do that. And we'll certainly share any of those experiences with you, and there will be opportunity to partner, hopefully, within those.
Because there's a question there about networks, and networks are relatively easy to establish and harder to sustain. This obviously is a network. It's a loose network. The webinar community as a network, and it's how we try and keep in touch without dragging people to meetings the whole time. But as Roisin said, increasingly we've had requests from the other groups like the Irish Hit Factor Database Network, where we can bring QI into what they do. And it just, so it gives a clearer purpose to them getting together in their network in the first place. And it builds on what Caroline Keneally's done with the Decontamination Network nationally, where it changed a network of people who used to meet to discuss issues of decontamination, I guess, to be a community of improvers. And we're increasingly, we'll be working with more and more groups like that, where they work on their ideas and we merely support them.
And obviously one of the things is we are a small team, so
Yes.
we can't spread across everywhere. So we are working as well on the use of technology, and for example, with the QI Toolkit, we are planning to do another QI Talk Time webinar on that, specifically on the use of it, and we're developing a demo toolkit so people can see one that's completely filled out from start to finish, which hopefully should help people. And alongside that, we will be developing further content, because that, I think, is one of the challenges in organisations, is how people actually, the methods through which they do their improvements. So if there's a standard method, often that can work very well for people in terms of learning and off each other and sharing. So that's something that we're advocating and has worked in some of the test sites that we've used the toolkit in. So certainly we will be providing more education on that throughout the year, which hopefully should assist you if you are hoping to build your own QI knowledge and expertise within your own teams as well. Yeah. Any other questions from anyone online? We've 45 people online, so you're very quiet. Any suggestions for further talk times as well? We'd be very open to those. And I suppose one of the things you talked about was that piece around culture and collective leadership, Philip, and I think that's something that resonates and is really important. And maybe if you could elaborate a little bit on that.
I suppose, well, first of all, you know, I guess the HSE is set up as a command and control organisation, centralised decision making for a widely dispersed delivery organisation, completely not set up to succeed. You cannot manage health services in that way. I have no span of control over improvement work that goes on in Tralee at this point in time, and I'd be very foolish to try and establish that kind of span of control. So the evidence on leadership has been comprehensively reviewed by Michael West, and what his summary of the evidence, and it's a very comprehensive summary for the King's Fund, says very clearly that collective leadership is the only form of leadership really that kind of works in complex delivery like healthcare. And what that really means is everybody can lead. There's obviously rule sets, there's still a hierarchy of decision making at times, but it's based fundamentally on mobilizing everybody's leadership. So a leader is the person who mobilizes other leaders. So if you're a leader of a team, the extent to which you're a successful leader is the extent to which you can see members of your team starting to lead on elements within their own area of understanding and expertise. That's the effective leader, and that's the kind of leadership that works in healthcare. So that is a bit of a culture shift. I mean, our staff survey shows that we do have to shift our culture, and you know it is improved from the previous staff surveys. That was good. Could we rest on our laurels in relation to that? Well, certainly not. There's still a whole series of very clear messages coming from our staff through the survey, and you know it may not have been a huge sample, but it was a large enough sample to get some very clear messages, and we need to be in dialogue with our staff to make sure that we understand the why of some of those responses that people gave, and in that way come up with solutions that address issues of people feeling disempowered, or people maybe you know, bullying, for example. There's bullying in every health service that I'm aware of, in that it's an aspect of society, unfortunately, but it's something that we need to eradicate and we need to get better at dealing with. So yeah, so that's really the kind of culture shift I guess we're talking about. And look, changing culture takes time, but we're all chipping away at it, I think. I'm not going to change the culture, and Roisin, I don't know if you are either, but maybe together we all will start to nudge the culture in the direction of this, some of the ideas in this document and other thinking that there is on culture and healthcare.
And just following on from that, there was a nice recent QI talk time actually on the co-lead intervention kit from UCD, which we've linked in with that. So have a look back at that, and it might give you some tools that you might be able to use and integrate.
And co-lead means collective leadership. It's a slightly misleading term. Sounds like it's two people leading together or something, but actually it's collective leadership.
Yeah. Well, I think without further ado, we'll keep it to that. So that was 40 minutes. You still have time to grab a coffee at the end of your lunch break. Thank you so much.
Assuming you're getting a lunch break.
It's assuming that, yeah. So thank you so much for everybody who's logged in. I definitely see some new QI talk timers, which is fantastic. This platform is done on a fortnightly Tuesday. On a Tuesday, so between 1 and 2. The website has got the next webinar up, and we will be updating that schedule in the next week for the next few months. So we have some exciting talks coming up. So the next one we have on Tuesday the 28th of January is with Juanita Guidera, who is the QI facilitator for staff engagement for quality, and she's going to talk about leadership skills for engaging staff in QI, which I think follows on nicely from today's talk in terms of that engagement piece and how do you get that started. So that's Tuesday the 28th of January. We'd be really delighted to hear from you, both myself and Naomi. Thanks, Naomi, for your help. Would love to hear from you if you have any thoughts or comments or suggestions for QI Talk Time. We are going to be doing very closely after a talk time on the National Quality Improvement Team QI Toolkit, which is a great one again to get started in terms of your QI methods. And thereafter, we're hoping to do a measurement series with both our colleagues here within the National Quality Improvement Team and some UK speakers, hopefully. So that will be coming up as well. So stay tuned, and if you're not already on the QI Talk Time mail list, please email Naomi. Her email address is at the bottom, and you can be added to that.
And just, there's another significant date before the 28th of January. Roisin's getting married, so just...
stop.
I thought you should all know that, and join me in wishing her all the best for that giant leap of faith.
Thank you for that.
Coming up later in January.
Thanks for embarrassing me. Thank you. Thanks. So yeah, I won't be at the next talk time, but I'll leave it in Juanita's capable hands. Thanks very much. So without further ado, we'll log off, and thanks again for joining, and we hope to see you at the next talk time on the 28th of January. Thanks a million.